Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Fever occurs frequently in ICU patients. It is often an indicator of infection, but can have multiple non-infection causes in critically ill patients. In today's episode of the podcast, we will discuss the evaluation of new fever in the ICU adult patient. Our guest is Dr. Kalil, a critical care and infectious disease physician. Dr. Kalil is professor in the Division of Infectious Disease and director of Transplant Infectious Disease at the University of Nebraska Medical Center. A renowned clinician, educator, and researcher, Dr. Kalil has received multiple distinctions, including the 2021 Scientist Laureate Award at UNMC. Dr. Kalil is an author of multiple peer-reviewed publications and is one of the co-authors of the 2023 Society of Critical Care Medicine and the Infectious Disease Society of America Guidelines for Evaluating New Fever in Adult Patients in the ICU. Andre, welcome to the podcast.
Thanks so much, Sergio. Really a pleasure to be here.
So I would like to start with asking you, why should critical care clinicians care about this clinical guideline or this topic of new fever in the ICU?
Yeah, so very important question. The fever is really something that we deal pretty much every day in the ICU, and there are so many, causes of fever that it becomes sometimes quite complex and difficult to discern the reason for the fever. And some of the reasons can be quite severe, quite serious. Some of the reasons quite mild. Some of the reasons can be just secondary to the natural history of some surgical procedure. But the reality is, it is critical for us at the bedsides to really understand the reason for the fever, because that can be something quite relevant for the management and the treatment of the patient.
Perfect. And I know that, as we mentioned in the intro, you've been part of the 2023 clinical guidelines, which were an update of 2008, and are really focused on adult patients who are not immunocompromised. Although I would imagine that a lot of the discussion also applies to immunocompromised patients, but that's a little bit out of the scope. But what I wanted to ask you to start the discussion is, how did you define in the guidelines fever in the ICU patient?
So, the definition that we use in the guideline was the temperature of 38.3 Celsius. And that's pretty much kind of the number that has been used in a large historical cohorts and population studies, trials. But we in the first paragraph of this fever section of guideline, we spend a little more time trying to explain to the reader that there are nuances on this, and this is really, really important, because we as a clinician, I cannot really wait for a specific cutoff to define fever in a good number of my patients. I'll give an example. If you have a patient that is, let's say, 25 years old with the meningitis, likely you're going to see a very brisk fever in these patients. They usually have a pretty robust immunological system, inflammatory reaction, and you're going to see fever quite high, quite fast. But on the other side, if you have a patient in ICU that is 80 years old, let's say even with meningitis, let's use the same syndrome, right? The same infectious process. It's very unlikely that the patient is going to have the same brisk response as the 25-year-old, and it may take longer for the patient to develop fever, or the patient may not even develop significant fever. So the point here is that, while we do use the 38.3 as the usual fever cutoff, you really have to individualize to your patient. I'll give another example. I have a substantial number of immunocompromised patients, solid organ transplant patients, bone marrow transplant patients, in which they chronically take medications that make the fever spike much more difficult to happen. And a lot of times they know their baseline temperatures. One of the things we talked in the guideline is that if the patients already know where they live in terms of range of temperatures, that can be very helpful because sometimes just 1 degree above whatever baseline they live can be something quite substantial and can be defined as fever. So really, try to avoid fixed cutoffs and try to individualize the temperature according to your patient's age, patient comorbidities, patient medications, because that's going to be way more meaningful for you to define fever than using, one size fits all for, certain numbers. So that's kind of the latitude that we provide in a guideline.
Perfect. And I think like all guidelines, right? They're anchors, they're frameworks for us to organize our approach. But at the end of the day, we have to think of the individual patient in front of us and use our clinician hat and also understand that sometimes there's subtleties that are unique to the clinical situation that we are dealing with. The second question I wanted to follow up that was, obviously when we think of fever, most clinicians immediately jump into the thought of an infection. But in the ICU patient, there are many non-infectious causes of fevers. Could you just give us maybe a quick commentary, Andre, on some of the most relevant ones that we should at least keep in the back of our mind when we're evaluating new fever in the ICU?
Absolutely, Sergio. So we tend to, when we're in medical school and in training, there's a tendency for all of us to associate fever with infection. It's almost like a knee reflex. But the reality is there are many causes of fever in the ICU that are not related to infection. And this is not just semantics or just like, just a little bit of a differential diagnosis. It is critical because some of these causes of fever actually demand a whole different diagnostic and treatment approach that can actually impact in the outcome of the patient. For instance, you can be admitted to the ICU with fever of unclear source, and turns out that the patient, for instance, has a massive myocardial infarction. It takes a little bit sometimes for the diagnosis to be made, but you can have fever simply from the fact that the patient is getting a myocardial infarction. Sometimes patients have a adrenal insufficiency that were not diagnosed before the patient come to the ICU, and adrenal insufficiency itself will require steroids and other treatments that actually in order to be treated, in order not only to bring the fever down, but in order to be treated. And the same with MI. I mean, you're going to treat MI with thrombolytics, whatever needs to be done. It's not going to be antibiotics. The same way patients, we see commonly patients with pancreatitis. We are a referral center for a liver transplant, and a lot of times patients have chronic pancreatitis and sometimes end up even with a pancreatic transplantation as well. And this itself can cause significant fever, and sometimes it's very difficult to distinguish fever from just an acute pancreatitis on top of chronic pancreatitis with, let's say, with necrotizing pancreatitis. For instance, another situation that's very common in the ICU, we are a referral center for oncology patients and bone marrow patients, and sometimes you see patients with a tumor lysis syndrome, patients with transplant rejection, and all these things that we approach in a guideline are really important syndromic process that can cause substantial fever, can simulate infectious process, but actually require a whole different treatment approach. So to look for non-infectious cause of fever is really important because that can change the management dramatically in order to know exactly what the patient needs. So when we see these patients at the bedside, we have to have your mind pretty open to both infectious and non-infectious sources of fever.
Perfect. How would you recommend, or how do the guidelines recommend that we measure body temperature in critically ill patients?
That was something that it really took a substantial amount of time and discussion among the guideline members because it is really important to define how can we do this in a way that can be more systematic, it can be more practical, and can be available as well in the ICU. It turns out that we don't have any of the kind of the usual traditional methods that can prove to be superior to the more rigorous methods that we've used in the past, and we don't use so much in ICU, but that we've used in the past, for instance, with the pulmonary catheter, with a bladder catheter, with esophageal probes. So all this, both the bladder catheter and esophageal probes that still we have available in ICUs, we don't use so much more the PA catheters as we used in the past. But these really bring a much more reliable measurement of the central temperature. However, not every ICU is going to have catheters, probes, and even less esophageal probes. So the reality is that if by any chance the patient does not have any kind of this more rigorous kind of methods, then the next step in terms of measuring temperature will be rectal and oral temperatures. And even though both rectal and oral temperatures are not also that simple, because it really, each one has its barriers. Let's say, oral, if the patient's intubated or having issues related to the oropharyngeal area. But we found, looking into the all evidence, that rectal and oral temperatures are more reliable than tympanic and some of these skin probes and temporal probes and so forth. So the seems that they just become a little more reliable in terms of measuring every day. The tympanic temperatures that also are used frequently in different places requires way more maintenance, calibration, and actually can end up with a 1 to 2 degrees wrong temperature in terms of either upper or lower temperature. So the point is, the reason why we didn't recommend tympanics, because it seems to be way more variable and less predictable than rectal and oral temperature. So that's why we, at the end, looking into all the evidence, we believe that in the absence of a esophageal or bladder probe, the most reliable sites to measure are going to be oral and rectal. And this is important, because whatever method you choose in the ICU, you want to make sure that you have a consistent approach, meaning that you don't want to use one method here, one method there, one method one day, one method other day, because that's going to really make the comparison very hard. I mean, when you change the method, you change the variability. Once you change the variability, you may end up with taking action when actually all you're seeing is the variability between the methods. So whatever method you choose, try to make sure that you have that consistently used in your ICU.
And I think it's always interesting, right? Like how for anything we do in medicine, there are layers of evidence, and maybe not the perfect evidence, but there's always a lot to be learned. And you mentioned tympanic and maybe skin temperature, which unfortunately, because they're practical, have become widespread throughout ICUs in the country. But yet those are the least accurate, right? And I think it's important for our clinicians to understand what the evidence says regarding temperature measurement.
Very important, Sergio. Actually, sometimes what's the most practical is not the most accurate, and this is one good example.
So every time I'm on call, Andre, I will get almost every single time I'm on call, I get a call from a nurse for a patient who has a fever asking for treatment. What is the current recommendation based on the available evidence in terms of treating a fever itself with antipyretic medications?
So, very important question, Sergio. Generally speaking, let me divide this answer in two factors. One, if it is infection related, let's say if you think that the fever is infection related, most of the time, the vast majority of the times, fever is really a part of the immunological response to the infection. Actually, fever tends to increase the recruitment of lymphocytes, T cells, B cells, and it's part of how we defend ourselves against the infection. So, low-grade fever, actually, it's something that it very likely can be beneficial in most of the infections process. The problem is when the fever starts to get to a level where can compromise the hemodynamics of the patient. So when, if you're talking, let's say, in a non-infectious process like a malignant hyperthermia, or a patient with some kind of neurological disorder that can, in which the fever can trigger seizures or something, of that complexity. So these are situations where maybe, it's not unreasonable for us to have a lower thresholds to use antipyretics, but the guideline looking for most of the reasons that cause fever in the ICU does not suggest the immediate treatment with any antithermic approach, including antipyretics, just because most of the times they will not be beneficial, including patients with sepsis. There were several sepsis clinical trials done in the past, in the last couple of decades, looking for the use of antipyretics as potentially something that could benefit the outcome and survival of these patients, and didn't do anything. Actually, there are animal studies showing that actually abrogating the fever can potentially even be harmful. So the point is, there is really no data of benefits. There's data showing no benefits actually given antipyretics as a general rule. So I think to make the answer, quite objective, is that we do not recommend as a general approach the use of antipyretics, but in special situations in which the temperature can really be detrimental to the patient, either because of the level of the temperature or because of the underlying disease, like a neurological disease, or a patient, let's say, in post-cardiac arrest and situation that temperature can be detrimental, then there's a situation that it is okay to use antipyretics. So I think we give a little bit of this latitude to the clinician, but in general, it will not be very useful.
Yeah, and I think that's an important point, because another commonly I think utilized treatment in the ICU that really has no evidence, and we've been just doing it because that's what we've been doing for a long time. So I think having that pause to think about it, is it really indicated, and the situation probably will help. At a very superficial level, Andre, this was not a focus of the guidelines, and then we'll go into the further evaluation. But any general comments on your stand as an ID, a physician, on empiric antimicrobial, antifungal, antiviral therapy in the ICU? Obviously, like you mentioned at the beginning, not all fever is infectious, but if it is infectious and the patient's sick, probably getting the right treatment soon is very important.
Yes. So one of the things that's really, in my practice, I emphasize very much to all my trainees and colleagues, is that if I do believe that by my initial clinical assessment, the cause of the fever is infectious, it is, especially if the patient is critically ill in the ICU, time is of essence. Absolutely, time is of essence. And I believe that there's nothing wrong and nothing risky about actually starting antimicrobials according to the history and physical examination if you have a good suspicion of infectious process causing the fever. So I think this is really important because in the worst case scenario, if your clinical judgment is wrong and turns out that patient does not have infectious process, you can always stop antibiotics in the next 24, 48 hours. You don't need to keep giving this, for a long time. But if you are right, and if your suspicion of infection is high and you're right, you really may end up not only improving the treatment of your patient, but you may end up improving the chances of surviving from this infection, because there's plenty of data showing that in patients that are really critically ill, secondary to infection, they can benefit from the early administration of antibiotics, especially in patients that are in septic shock. But the point is, sometimes it's very hard to distinguish which patients will benefit more or less. I'll give an example. Some patients that are quite immunocompromised, let's say patients that are taken, let's say, tacrolimus, myforticine, and steroids for years from a solid organ transplant. A lot of times these patients will come without a lot of symptoms of infection, but you already know the patients, you already know the history of these patients, the history of infection. A patient is probably having, like, let's say, a recurrent infection of, let's say, a pneumonia or a UTI or something that you already know the likelihood that this patient is developing a substantial infection, but the patient is not showing, like the overt clinical signs and symptoms. This is the type of patient that start antibiotics early is going to be critical because these patients will crash and burn very fast if you do not start antibiotics on time, especially because they're already very immune compromised. So the point is, again, we have to individualize the situation. We have to be aggressive about starting antibiotics when they have a suspicion, and we have to be aggressive about stopping antibiotics when the patient does not have infection. So in my own practice, yes, if I have somebody in the ICU critically with fever and I do have a suspicion of infection, I will start empirical antibiotics until I get a better understanding of both the diagnosis and the natural history of the situation.
Perfect. Let's talk about imaging studies and critically ill patients with new fever. How would you approach a patient who's been in the ICU, now has a fever? What are the imaging tests that you would order? How would you think about it? And what do the guidelines recommend?
So the guideline recommends chest X-ray as a kind of a general rule for patients with fever in the ICU, and I think is reasonable because with a plain chest X-ray you can catch the beginning of a pneumonia, you can catch a pleural effusions, you can catch abscess, you can catch pneumothoraces. I mean, so many things you can diagnose with a very simple and quick image like a chest X-ray. So I think it's just reasonable to believe that chest X-rays should be part of your initial approach, especially when you're just kind of first seeing the patient. So I think it's very reasonable. It's available. It's safe. You don't need to get the patient out of the ICU. They usually can do it at the bedside. So I think that's something that I think is quite reasonable that the guideline recommends as a general. Now, all the other image tests will depend on the history and physical examination. Let me give an example. We suggest the addition, let's say, of ultrasounds, either POCUS or formal ultrasounds, when there are indication of a focus of infection. For instance, if you have somebody with a abdominal pain or transaminases, elevation of transaminases or bilirubin or alk phos or suspicion of cholecystitis or suspicion for appendicitis, when you have somebody that really has clinical symptoms that suggest abdominal source of the fever and potentially the sepsis, then this is a situation where images definitely can benefit to understand, what is the extent of the infection and what needs to be done in terms of drainage or surgery. So that's when we recommend the addition of ultrasounds and the addition of CT scans, depending on each situation. I think the bedside ultrasound can be quite useful just because it is usually, if it is available in the ICU, it's right there. You don't need to transport the patient to a CT scan in another part of the hospital. It's less radiation. So there's a lot of benefits of doing the bedside ultrasound, and I think can be quite useful. But we do not recommend just as a doing just in case if you don't know where the fever is coming from. The guidelines recommend that you have to really have some indication that of the focus of the infection in order to maximize the yield of the ultrasound. I mean, and you think about this is like almost every test that we do in the ICU. You have to have a little bit of a prior, correct? You have to have a little bit of a clinical suspicion of the focus in order to do certain tests, and the image is the same. If you have a suspicion of let's say of a respiratory infection, and by chest X-rays or by clinical symptoms, you can go ahead and do a bedside ultrasound of the lungs, lung ultrasound. You can look for parenchymal change, you can look for pleural effusion and so forth, and can be useful. It can definitely be very useful to understand the extent of the infection of the lungs. But again, the same story. What's your prior, correct? What's your clinical suspicion? We always go back to the history and physical examination to delineate which tests are going to have the higher probability to help you to define what's happening with the patient. So we talk about bedside ultrasounds. We talked about formal ultrasounds. We talked about CT scans of the chest, CT scans of the abdomen and pelvis. And when exceptionally, again, I say exceptionally because even in my practices, rarely I will need to do that. If you reach a point where you really you're struggling to find the source after extensive examination and image, including CT scans, potentially you can think about doing PET scans. Again, I don't think that we should recommend PET scans as a routine in any ways and form because it is a test that will only be helpful in very, very exceptional situations. The vast majority of the situations, the ICU will be able to make the diagnosis by clinical examination and by traditional image like X-rays, CT scans, and ultrasounds. But when you're really against the wall at the situation where you don't know what's happening and you cannot find the source, we recommend a PET scan as a potential tool to find the focus of the infection because it's a situation that really becomes quite frustrating after a few days of investigation and in which the patient does not have a diagnosis. But again, I emphasize that this will be more the exception than the rule.
Perfect. And I've been in practice for many years. I'm sure I've had a couple patients had PET scans, but I never ordered it myself. So I'm sure that by that time, I would hope that our critical care colleagues are brainstorming with our ID colleagues at the bedside, right?
Correct. Exactly right. I like the word brainstorming. That's a good one.
So let's talk about blood cultures in the critically ill patient with fever. First, if you could just tell us what the current recommendation is in terms of how many blood cultures, how much blood, and the timing of that. And then I would like to hear your comments on what do we do or don't do when there's a central venous catheter in place.
Yeah, Sergio, this is really important because I've had a few messages from friends and calls from friends after the guideline was published about this as well. And as you know, through the years, most hospitals and ICUs learn to minimize the systematic collection of central line cultures for any reason because at the end, when you see a lot of studies have shown the amount of blood cultures contamination from central lines, and sometimes people end up getting over-treated with unnecessary antibiotics. And so, a lot of places now have rules and electronic health, records. Basically, when you order these cultures, a lot of places automatically go for 2 peripheral cultures to avoid the collection of central lines. And the idea here is to minimize the contamination. So this is, I understand why this has been done in many, many places as part of controlling the unnecessary use of antibiotics for contaminated cultures. But I wanted people to understand that our guideline is dealing with a different patient population. This is not everyone in a hospital that is not very ill or has some fever or has a reason to have a culture. And this is a patient that is critically ill, requires an ICU bed, has fever, and this is really important because this is not the same as a patient that's in the ward, very stable, that still has other reasons to have fever or infection. So, in a patient that is in the ICU, is critically ill, has fever, and if the patient has a central line and you don't know the reason why the patient has the fever, that's a situation where you have to literally sit with your whole team, sit with the nurses and the clinicians and the trainees. Everyone say, listen, this is a situation where I need a collection of blood from the central line and I need a collection of blood from the peripheral vein. I need both at the same time because I want to know if by any chance the cause of this fever is coming from a central line infection. This is really, really important because a lot of our patients in ICU, not only sometimes they have lines placed in the ICU, but sometimes they have lines placed outside the ICU for a long time. I have patients come to the ICU with dialysis catheters with central line catheters for other reasons. They're getting fusion chemotherapy. And a lot of times they have these lines for weeks, sometimes for months, for a long time. Sometimes they're in the wards for a few weeks. So the fact that the patient has a central line, the fact that you don't know what's causing the fever, should be a big trigger for you to say, you know what, I have to collect blood from the central line and from the peripheral veins, because that's going to give you a sense of what's happening. The reason why we do that is because we already know that if you have a differential time of 2 hours or more between the culture positive in the peripheral vein versus the culture positive in the central line, that's going to be a highly indicated that the patient has a central line infection, and likely the central line will be eventually have to be removed, especially if the patient is getting critically. So this is really important. The other thing I want to mention, Sergio, is that if you're going to collect blood from the central line, the guideline recommends at least 2 lumens from the central line. A lot of these central lines have 2 lumens, 3 lumens or more. And the reason why is because if you collect at least from 2 lumens, you're going to increase the yield of catching an infection that is contaminating or infecting the scatter. So it is important to make sure that you get this procedure done. The last thing I want to mention about the blood cultures that's important is the yield of the blood cultures. Whatever blood cultures you do, whatever place you do, is very, very proportionally related to the amount of blood that's collected. So if the amount of blood collected is too small, you may end up with a false negative blood culture when the patient is really getting septic and bacteremic. So you don't want to get into the situation. You really want to catch these bugs if they are in the bloodstream. So you want to at least put the minimum of 10 mLs in each bottle of these blood cultures. The way the guideline recommends is that you can collect 2 bottles for aerobic culture, 1 bottle for anaerobic culture, so 3 bottles for each site. Let's say 3 bottles for the central line, 3 bottles for the peripheral vein culture, and it's going to be 10 ml in each. It's going to be about a total of 60 mLs. This is really important because if you skimp in the amount of blood you're collecting, you may end up with a false negative culture that can be quite detrimental to the treatment approach to the patient. So these are kind of the general approach that the guidelines recommend for these blood cultures.
And like you mentioned, I think this is an important aspect of care for practical reasons, but also with our emphasis on trying to reduce catheter-associated bloodstream infections. I think people have sometimes gone too far in terms of not checking cultures. And when the clinical situation merits, we should do what's best for the patient, and understanding where that infection is coming from obviously is very, very important. And I think that time to positivity is something that people need to take into account and make sure that, like you mentioned, Andre, that we're measuring from more than 1 lumen in the central line when suspected, and getting also a peripheral one at the same time, and using that time to positivity to try to figure out if it's the central line or not.
And Sergio, if you allow me, just one thing that I want to reemphasize. I'm sure that all of us working at SU, we've read the sepsis guidelines and other guidelines, but just emphasize again and repeating again that ideally this culture should be collected right before the antibiotics are being started. So you don't want to delay for any minutes the administration of antibiotics, but we all know it takes time between putting the order, again, the pharmacist to mix the antibiotics and bring to the ICU. That's the time to do blood cultures. The yield of getting a blood culture positive will be tremendously increased if they are collected before the initiation of antibiotics. So that's something that should be really a big effort in all ICUs.
Perfect. On the same note, I guess, similar dynamic, when and how should we get urine cultures?
Yeah, that really becomes a little more complex than blood cultures, because the problem with the urine cultures is that they tend to really be a little more difficult to really interpret, because there is a very common process for contamination of urine, especially in the ICU, because a lot of patients are going to be hemodynamically unstable, requiring Foley catheters, and becomes very difficult sometimes to collect a specimen, a urinary specimen that can provide a reliable result. So the recommendation that we make in the guidelines is that the urine really has to have pyuria. The patient has to have symptoms, and the collection has to be really as sterile as possible, and that includes patients that already have a Foley catheter. In the vast majority of the times when patients develop fever in the ICU, they already have a Foley catheter, either because before they came to the ICU or a few days before you are seeing the patient. And if the Foley catheter is really sitting there, you basically, the way that you want to do, if you really are concerned about the urinary infection, you're going to have to remove this Foley catheter, put another Foley catheter if the patient really needs, and collect urine from a fresh catheter. This is going to really make your collection much more reliable and much more informative in terms of what to do with these results. If the patient has any history of UTIs, any history of lithiasis, hydronephrosis, pyelonephritis, anything that's suggestive of UTI, and now you're collecting a sterile urine with a pyuria, that's going to be a urine that really is going to go for culture, for urine cultures, and is going to have a good yield to bring pathogens that need to be treated. So the key point is we recommend not collecting urine from patients that already have any urinary catheter in place, because at that point, when the catheter is staying there, the chance of contaminations are too high, and you may end up treating the patient for a culture positive that has nothing to do with the fever, has nothing to do with what's happening. You may end up exposing a patient to unnecessary antibiotics when the patient needs another treatment approach. So this is something that we emphasize very much in the guideline.
Perfect. And as we move forward, what would be the recommendation on testing for viral pathogens? Obviously, we're in the winter, respiratory seasons around, coming out of COVID-19 pandemic. COVID's still around. I have definitely diagnosed COVID in some of my patients in the ICU after several days. But what's the current recommendation on viral pathogens?
So they are quite useful in general because both the nasal swab and the pneumonia panel from the sputum, both of them, they add a little bit of different information, but complementary information. So for either patients that are intubated or not intubated, if you have a patient with with respiratory symptoms, signs and symptoms, definitely it's something quite useful to do, because you can not only diagnose a potential pathogen that is causing the symptoms, but also you can define if the patient is going to need antibiotics or not, correct? So for instance, I see now, I'm just the last few weeks, I was in service, I've seen patients with in the ICU with rhinovirus, parainfluenza 1, parainfluenza 3, metapneumovirus, RSV. I mean, I've seen almost all respiratory viruses in the last few weeks, and the winter is just beginning. So these are really important, because some of these viruses have specific antibiotic treatment and some don't. And knowing which viruses are infecting the patient or bringing the patient to ICU are going to be really important, because that's going to change your management. The other thing that I want to mention, Serge, that's very important is not only it's very easy and you're going to have the results in 1 or 2 hours, but also it's very important to not forget that patients can have a positive, viral pathogen, in a panel, and the patient could have also a bacterial pathogen. That I'll give an example. I have a patient that last week that the patient had a rhinovirus, and it turned out that the panel just showed rhinovirus, and the patient is quite ill, developed respiratory failure, ended up needing to be intubated, and it turns out that after the intubation with the trach aspirate, the pneumonia panel showed a Staphylococcus aureus, and the culture also showed Staphylococcus aureus. So the point is, when the patient was being seen outside the hospital, it was all rhinovirus infection, came here to the hospital, was diagnosed with rhinovirus infection, progressed to bacterial infection, and end up with Staph aureus pneumonia. So why this is important is because the We cannot forget that a lot of times in the ICU, you're going to see patients with co-infections. And they don't need to be even immunocompromised. They can be immunocompromised or not, but about up to a third of the patients that have CAP, they have co-infections with between virus and bacteria. So that's something that I want to make sure that people understand. The panel is going to be very important to define what kind of pathogens are potentially causing infection, but the panel will not define the entire history. If the patient is progressing, if the patient has a viral pathogen that is progressing to a worse disease, it could be progression from the viral disease, like COVID, could be a progression to a severe COVID, but could be a progression to a bacterial infection as well. So it's very important to keep that kind of diagnostic approach always up 24/7 to make sure that you understand if the progression to respiratory failure is secondary to the natural history of the virus or it is secondary to a post-viral bacterial infection. All these things have to be evaluated day by day on real time to our patients.
Perfect. And what about in closing the role of rapid biomarker tests like PCT and CRP?
So PCT and CRP, the way the guideline dealt with was the following. We recommend that if you have a low probability of infection based on your history and physical examination, you just kind of don't know what's happening. You don't find what's happening, but patients still having fever in the ICU. It is reasonable to check either Procal or CRP, either one or both, whatever you have in your hospital. Each hospital has different laboratory measurements, but it's reasonable because you're a little bit lost. You don't know what's happening. The patient's having fever. There's two reasons to do these biomarkers. One is because if the biomarker comes quite elevated, it's really is going to trigger you a more aggressive approach, looking for infection, looking for what's happening with this patient. Because even though the history and physical are not that impressive, now you end up, let's say, with a very high PCT or a CRP. That's going to trigger you to think, okay, am I missing something? What's happening here? The other reason for doing that is because, once you get to biomarkers, and a lot of times when you get called to see these patients, the patient's already getting a couple of antibiotics. Let's say it turns out that the PCT and the CRP are, normal, like 0.05, whatever normal is in your lab, it's really normal. There's nothing. You repeat next day, still normal. So, now you start to see that you don't find a focus of infection. The patient's doing well. And the biomarkers are completely normal, even when you measure sequentially. Well, that's a situation where you can say, well, you know what? I think it's time to de-escalate antibiotics because I'm not seeing infection source of fever. So these are the kind of the situations where the biomarkers can help. But I think really important, Sergio, that I want to mention here too, that we discussed as well in the HAPFAP guideline in the past, is that these biomarkers, they alone, they are not sufficient to rule out infection. Let me tell you one example. You have somebody with a high suspicion of infection. This is what the guideline says. This guideline says, let's say you have somebody with a high suspicion of infection. You really think the patient has infection causing a fever. If the Procal or the CRP comes normal, really, it should not change your management. The biomarker being normal initially, it should not change your management, meaning that if you think the patient has a infection causing a fever and the critically ill situation, you give the antibiotics, you treat the patient independent of these biomarkers, because the biomarkers can take a while sometimes to go up, sometimes they don't go up very much. So the point is, they are not good for you to really rule out the infection, but they are good for you to understand what's happening with the patient in terms of a need for antibiotics in the next couple of days. They can help you to complement when you have a low suspicion and you don't know what's happening with the patient, but they will alone never be decisive about what needs to be done. Remember, these biomarkers are only complementary, and you have to take with a grain of salt because, again, your clinical assessment, your physical examination will be critical. And if you have a high suspicion of infection, these biomarkers are not going to be very useful because you already know the patient has infection. There's nothing that you're going to gain at that point in terms of diagnostics. That's why we do not recommend biomarkers for patients that you already know that have infection source for the fever.
And I think it's very similar to how you might use D-dimers in the ED to rule out low suspicion PE, but it's not something very useful when you have a high suspicion. And I think it, like you mentioned, probabilities-based theorem applies everywhere in medicine, and using that appropriately is very important. Andre, really a lot of very, I think, practical, evidence-based pearls here that apply to daily situations in our ICU. So almost every day, I would imagine, at every one of our ICUs, there's somebody with the fever, and how to follow up on that, how to approach those patients, I think is very important. These guidelines are a great tool for our clinicians, and we'll link them obviously in the previous guidelines in the show notes. As we close, Andre, we like to tap into the wisdom of our guest outside of the clinical topic with a couple of questions. Would that be okay?
Absolutely.
So the first question relates to books. Are there any books that have influenced you significantly, or that you have gifted often to others?
So there's so many books. It's a tough question always, Sergio, because we like so many different things. But I would say that there's one book that really it was very impactful to me many years ago. It's already a little old, it's like in early 2000, but it's just absolutely fantastic book. It's a book titled Splendid Solution by Jeffrey Kluger. Basically, the book is about Jonas Salk and the conquest of polio. And the reason why this book is so phenomenal to me is because it shows the struggles and the barriers and all the efforts that Jonas Salk went through to develop the polio vaccine. And this is really remarkable because we are talking about 1950s, and everything you're going to read in this book is applicable to 2023. Basically, Jonas Salk was believed that the vaccine he developed was an inactivated polio vaccine, really would be effective, and he went against a lot of people that thought that this vaccine wouldn't work or potentially could be even harmful. And why this is important? Because Jonas Salk, in the middle of a horrendous polio epidemic in the U.S., was able to do a clinical trial that had even placebo arm that changed the history of the world. Jonas Salk clinical trial, it was a randomized trial that really changed everything that we do today. I mean, without the polio trial, unlikely we would be developing so fast what happened during the COVID pandemic with the new vaccines. Vaccine trials require randomization. Vaccine trials require placebo, and that's really what was done in 1950s. It was basically the very first vaccine trial done with so much rigor. And that book, to me, is a book that it should be probably part of medical school's curriculum all over the world.
Excellent. And I think, like you said, very timely to what we've lived recently, but also good science, right? It transcends the years. And when you said it's an old book, you reminded me of my grandfather, who instilled, a love to read in myself. And he would always tell me that old books are good because only the good ones get to be old, right? So he would say that in Italian, but I think that is very true. So the second question is something that you believe to be true in medicine or life that most other people don't believe or don't act like they believe.
That's great, Sergio. So what I would say is that I proud myself to being really a clinician that really does everything possible and impossible for my patients. I really, I just love it, being at the bedside and seeing my patients improving. And I think that's the lesson that I've learned throughout these years is that being humble is really critical for us. What I mean being humble is we have to understand our limitations. We have to accept our limitations. We have to accept the uncertainty of medicine. If you do not accept that uncertainty, likely you're going to end up not really treating well our patients. And the reason why I say that is because the moment that we accept our limitations, the moment we accept that medicine has uncertainty, we have to deal with uncertainty. You're going to look for the best that can be done for your patient. You're going to still be thinking, what else can I do to improve the care of my patient. And the guidelines, like clinical trials, all they do is they minimize the uncertainty of the medical knowledge, the medical evidence, correct? So what the guidelines do is they minimize uncertainty, but they don't remove the uncertainty. The same with clinical trials. So our job at the bedside is to translate what we see in the randomized trials, what we see in the guidelines to our patients. In order to make this translation, in order to apply this evidence, we have to understand the uncertainty, we have to understand the limitations of the data, we have to understand the limitations that we have at the bedside, and really invest in trying to really discover and improve the care of our patients by accepting that uncertainty exists, and that's part of how we can really do better at the bedside. So I think being humble and understanding that we have much to improve, much to do for our patients is critical for us to really do better at the bedside.
Andre, I think that's a perfect place to stop. I really want to thank you for sharing your expertise and your time with us, and for being part of these guidelines that, like you said, are important in decreasing the uncertainty at the bedside. But I agree 100%. Humility is probably the number one attribute that a scientist and a physician should have at the bedside.
Thanks so much for this great conversation, Sergeant. Congratulations on our podcast. I really enjoyed it very much.
Thank you.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.